Hi, this is Amy Perwal with the Polybio podcast, and my first guest is Dr. John Chia. He's an infectious disease physician who practices at ID Med in Torrance, California. He has published multiple papers on infection as a driver of ME/CFS, with a particular focus on the role of persistent enteroviruses in the disease process. In addition to his clinical work, he runs his own enterovirus research laboratory, EV Med Research, and is on the board of directors of the Enterovirus Foundation. And with that, John, hi. It's great to have you on here. Thank you so much for joining me.
Hi, it's nice to be with you.
Great. Wow. Okay. I'll jump into this. I already explained that you study enteroviruses. Can you give me a bit more background on just enteroviruses in general? It's surprising to me how many people are not even aware of the enterovirus family.
Okay. Well, human enteroviruses, this is the big category, actually has, large category called rhinovirus, the cold virus, which is about 200 of them. And then there's the enteroviruses that we classically refer to, Coxsackie virus A, Coxsackie virus B, echoviruses, polioviruses, etc. There are about at least 80 plus of them. But if people do genotypes of those viruses, there are probably over 130, 140 of them now. Ian Lipkin said one time he found 30 unique enteroviruses when he was working in New York. So there's quite a bit of this stuff. And these viruses cause probably 15 million to 25 million symptomatic infections. But most of the infections are very mild. Okay, it could be like a common cold. It could be gastrointestinal infections. But sometimes we see really serious infections when it really enters into the organs, like into the brain. Encephalitis or meningoencephalitis, both meningitis and encephalitis. And people never talk about this, but we see them. We see them at least, 10 cases a year. Meningitis one time was 80 cases in the summertime. And so that's when the viruses are actually spike in the water. And people ingest, the water, tastes good and didn't have any problem with it. The virus went right in, and then they can result in these infections. That's one of the most common way of getting infections is actually oral fecal. Yes. So either in a city like, Boston doesn't have a problem with water. Well, in California, we're in a drought eternally, right? So because we don't have any water, the water has to come from the north. And so they pump water from the aquifer underneath us. The aquifer are often contaminated with fecal material. And these viruses are shed in the feces. So when the water is pumped up, they usually are chlorinated. Eventually you get about 3 parts per million of chlorine. That will not kill an enterovirus. CDC's website will tell you this, actually. Groundwater is one of the most common reasons why people get it, okay? So what are the other sources of groundwater? Or like lakes, river, right? Ponds. And people in the summertime go swim in it, okay? Or in the ocean, in the brackish water, right? And the sewage gets dumped right into the ocean. And the virus in the sediments of the feces can actually float as far as 10 miles out. So people can dive in and they catch it. So it's not surprising that these viruses can occur in epidemic forms. Like the best example of it is the Lake Tahoe outbreak, right? I mentioned that at the conference. I said, this is the 37th year after the Lake Tahoe outbreak. To this day, we do not have a unifying etiology of the disease.
Exactly. Yeah. No, I think that's a point where I wanted to pause and I wanted to ask you, there have been documented ME/CFS, if you want to call it, or myalgic encephalomyelitis outbreaks. And some of them have actually been tied to enteroviruses, one in Iceland as well, correct?
Absolutely. So one of the best talk you might find online is from Byron Hyde. Okay. He has investigated a number of these, outbreaks. He summarized it in his book. Very, very well written. There's absolutely no doubt enteroviruses are the cause of this. Well, in Britain, they already experienced a number of these outbreaks, or they have looked at it. So they said, this is myalgic encephalomyelitis because a lot of people have muscle pains and they have brain and spinal cord, inflammation, it seems. So they call it ME. And ME was, and they heavily investigated the enteroviruses in the 80s and the 90s. Okay. Unfortunately, when Lake Tahoe outbreak occurred in 1984, and well, the background of it, to make a long story short, so it happened in the summer, right? And people who live in Incline Village, Lake Tahoe, what do they do in the summer? They will go into the water.
Swim in
right?
ponds, I was going to say.
Swim in the lake, right?
Okay.
There was a sewage spill the year before.
Wow.
This I gave in my workshop at the CFS back in 2016, I believe. Yes. And when I want to give it again this time, and people say, well, that's not, it does not, I guess they, in a way, they say it's not so interesting. Okay. They have no clue. They have no idea what they have missed out for all these years. I've been telling my patients that they have enterovirus infection for more than 15, 20 years, and nobody listened. It's ridiculous how this works. But anyway, so what happened was so the sewage spill and the virus goes into lake water. The one of the most common risk factors for getting enterovirus infection of the central nervous system is actually swimming in a lake or a river. Number one, the Russians figured this out, okay? Wow. Number two, contact with sick people, as you would imagine. Number three, drinking raw water. Number four, camping, okay? It's like, well, we didn't swim in the water, but maybe they splashed the water on their face, right? Yeah. And number five, drinking raw milk. Interesting, okay? Wow. So these have already been figured out by others. And Dr. Joseph Melnick in, I believe, Baylor University, Houston, has written tons of paper in the 80s linking the water with these virus outbreaks. They've done one of the best work. If people have ever even read the chapters on enteroviruses and then hear these little facts, they will connect the dots, and nobody even bothered. So that's the big problem with all this. Nobody else worked on it, and I've been doing this alone and for all this time. So what happened with Lake Tahoe was, so initially when Dan Peterson called up the CDC after he saw 20 patients at the end of 2 weeks, he said, wait a minute, why are they coming in with all this mental confusion, horrible, they loss of memory, cognitive dysfunction, orthostatic dizziness, they have body aches, they have nausea, they have diarrhea, and they look like they're really sick. 20 patients by the end of 2 weeks. He knew there was an epidemic. Yeah. He called up the CDC, they ignored it. Maybe that's too harsh of a description, but that's what ended up what happened. And so he started doing blood tests on these patients. And the only type of testing he could do at the time was Epstein-Barr and CMV, antibody tests. All right. Lo and behold, all those test results were sky high in these patients. But I have to put in perspective. In 1979, 1980, when the gay males started coming to the hospital for workup, and they didn't feel good. They have thrush and they have lymphadenopathy and all the stuff. Their Epstein-Barr virus and CMV test results were sky high also. So some of the people down where I am at UCLA, one of the visiting professor was Marty Lerner, and he was one of the CFS physician investigators. He actually made the comment, other people thought it was probably true, that Epstein-Barr virus has mutated and now killing the T cells. In 1984, actually, they found HIV. So that field moved on. In 1984, the chronic fatigue syndrome was coined in the Newsweek magazine because of this epidemic occurred in Lake Tahoe, right? Unfortunately, after, sometime after, the CDC really didn't pay any attention to this until maybe 2 years later. Then they probably collected some stool samples, some blood samples, and they sent it back. I don't think they really tried very hard to find something, okay? And they did IgM tests on the blood samples, and there was no difference between, the affected patients and the normal controls. And IgM test is such an insensitive test. You could barely find 13, when I did the IgM test before, it can barely find 13% positive. I mean, how can you use a test like that to diagnose a disease? I mean, 90%, I think, would be pretty good, right?
Yeah.
And they tested the stool for the virus, but unfortunately, these viruses are already in the tissues. I mean, for many, many years, I struggled with this. I said, why can't we find this in the stool, right? Because the CDC people reported long ago that there are people that can shed virus for months, okay, or even longer if they were infected. So why can't we find this? I mean, I can give you numerous examples for this, but that was one of the problems that eventually led me to believe that this stuff is actually hiding in the tissues.
Yes.
So, but it was not until, to go back a little bit, 1983, I actually started doing my infectious disease fellowship at Bethesda Naval Hospital, now called the Walter Reed Military Hospital, where Trump was admitted to last year. And so one of the first cases of enterovirus infection I saw was a Coxsackie B virus myocarditis. My boss attending famous infectious disease giant, Dr. Jay Sanford, took me to the bedside of this Army colonel who really looked like he was sick and suffering. He could barely even raise his hand up to shake our hands. And his heart rate was 150, and he just looked really ill. And Dr. Sanford told me this is called Coxsackie B myocarditis. I didn't ask him, Professor, how do you know? Can you justify to me? Because he knows. He's one of the probably the best in the world on this stuff. I went home, I read about Coxsackie B and echovirus, enteroviruses in general. And then for the next 10 years, I don't think I saw a single case. Okay. I tried to find them because we have tests like for Coxsackie B and echoviruses. And unfortunately, those were done in commercial labs that really don't know what they're doing. Okay. But they offer it, they charge arm and a leg for it. These are done by complement fixation tests. Okay. That's neither sensitive nor specific. I mean, if it's positive, it doesn't mean anything. If it's negative, it's meaningless also. Eventually, in 1995, we had a patient that went to a wrong lab, and they actually did the right test, which is called neutralizing antibody for Coxsackie B, 1 through 6. And for the first time in all these years, more than 15 years, I saw this positive test. I said, wow, I've been chasing this woman, trying to find out the cause of her chronic disease for 2 years. And this is the first time I actually got a positive test. So I called up the laboratory director in Philadelphia and asked him about it. And so he didn't give me the specifics, but he told me it's a neutralizing antibody. They have to work with live viruses. And he said, well, we're just better at this than other people. Well, obviously, right? So then I called up 3 experts in the world, in this country. Every single one of them asked me, by what method did you do your test? They all confirmed that the neutralizing antibody is the best test. That was not what the CDC did on the Incline Village patients. And by the way, we can only test 11 of these enteroviruses. There are more than 80 of them. So, you know, we miss a whole bunch of these viruses. But some patients, we can see really positive results. And we're lucky, probably 40 to 50% of the patients we can diagnose based on these virus tests. And we compared it to the normal people. As you saw, I showed that at the meeting. And the difference is night and day. There's these very high titers, you know, for these patients who are infected versus the normal controls, right? Eventually, so we still do that test, do those tests nowadays. That has to be done at this laboratory called ARUP. ARUP laboratory in Salt Lake City, Utah. And they do the neutralizing test for 11 of these viruses. We sometimes do them in the laboratory. Is really tedious. And they do such a great job. Well, you know, we're not going to bother with our time. So we send it there for all these testings. So every patient I see will have these type of testing. And by the time I used to get it done a month before, Some insurance won't pay for this, and depending which laboratory you go to get this blood test, and sometimes they refuse to send it to this laboratory in Salt Lake City because they're kind of competitors, like Quest, LabCorp, okay, and this laboratory in Salt Lake City are competitors, so they don't treat each other very well. Anyway, but that's where the beginning of this. In 1998, my son got sick the second time. In 1999, September, I diagnosed him because I drew the blood from him about 2 weeks before we moved to another house. He was already sick for a whole year, and I didn't even know my son was sick.
Wow.
And I, in retrospect, I saw all the signs. It just didn't compute in my head because I was so busy seeing, all these patients. So he's Kawasaki B3 and 4 antibody levels were 640, less than 10 is normal. That's the highest you get. And mine was less than 10 and 40. So I compared mine with him first. And if I have that much, then I probably didn't really mean that much. So from that point on, we started to compare the patients with the normals. And that's how I showed that at the meeting. This took a long time. That little diagram there probably took us 2 years to do. And so that was the first thing. Then eventually, so because of these type of testing, we can actually go backwards and say, if I see a patient in the hospital, I listen to them, listen to their story, then I follow them, forward to see actually what developed, to them. Then we actually learn what acute enteroviruses infections are like, right? That is the number one thing. A physician must recognize what enteroviruses do to people. This is one thing I said at the meeting. People just sit at a desk or in the conference room, they're not going to understand this, right? We've seen some of these patients look so ill in the hospital, and you can't find anything. They don't respond to antibiotics, but some of them, we gave them a dose of intravenous immunoglobulin. They improve within 24, 48 hours because that's providing the neutralizing antibody for their acute infection, which is, sometimes can even kill these people. So anyway, since then, I probably detected 90 to 100 cases of myocarditis. Wow. You have to recognize the disease first. If you don't recognize it, it just fly right by you. Meningitis and encephalitis, neurologists often call strokes, are actually virus infection in the brain. We see them wake up in 2-3 days, and they will come back again in 2 weeks. They'll become comatose. We have transplant patients. They'll be like this. They'll come back every single month, be completely comatose for a week. Then they'll wake up and go out and come back. But we found the virus in the stool. This one is easier because they are transplant and therefore immunocompromised patients. So we learn from this what these viruses can do to people. Then we go say, how can we actually find a test that eventually can diagnose them right at the time when they come to the hospital? Unfortunately, that doesn't exist. We have molecular diagnostics like COVID, but those are not very sensitive. So we can do the nasopharyngeal swab. We can do the enterovirus RNA by PCR. We can do spinal fluid for this enterovirus PCR. It's very insensitive. Everybody assumed those would be 100% sensitive, and it's not true. Once we see a positive, we jump up in joy, okay? And so stool, and people always say you can carry this, so you find a positive stool enterovirus RNA is meaningless. We haven't seen a positive one in probably 20 years. Wow. So what are they talking about? We've done more than 300 stool samples. There's a disconnect here. This is something that we've been working on all these years. Eventually, we realized, a lot of these patients have gastrointestinal symptoms, right? So initially, they may come in with horrible abdominal pain, totally unexplained. And the CAT scans, that some even had angiogram to make sure they don't have a clot in the arteries. The pain is so bad. You put down a scope to look at the stomach, you don't see a whole lot. There's some little red areas, okay? It's like very benign. You don't see a huge ulcer. They take a biopsy. We can actually grow the virus out of the stomach.
Well, yes, I've seen your papers on that.
Right.
Right.
That's right. That's actually how it worked. But people look at that and say, oh yeah, okay. So they don't see patients. They don't realize how common these things are. People with functional dyspepsias, I mean, 25, 30% of our US population have that complaint, chronic complaint. And they come into the hospital, oftentimes like 7, 10 patients at a time, okay, in a week. And they all complain of abdominal pain. And all the people kind of realize, yeah, they kind of all have the same thing, but then, they get better. And that was the end of it, right?
Wow,
They never
interesting.
diagnosed it until we biopsied them.
Got it.
We,
So to recap then,
yeah.
a big problem is that first, physicians are not even aware of enterovirus infection generally, and they don't really know how it presents in patients. So they're not even aware that this is something they should be looking for. Then second, the standard testing that they would do, even if they were trying to look for an enterovirus, is actually usually not accurate. There's only one lab that really does it accurately with the neutralizing antibody test, and the other testing is almost worthless. And then last, the virus doesn't even necessarily persist in fluids that often, and you're more likely to find it in tissue. So if you really need to confirm the presence or absence of the virus, you need to get a tissue sample, for example, via an endoscopy or a piece of the gut lining, right?
You're absolutely correct.
Okay.
So this is the difficulty we encounter. So people that do research, collect blood samples,
Yes.
spinal fluid samples, da 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 da. The problem is, we're right in front of the patient at the bedside, and we're trying to scratch our head to figure out how do we find this thing. And we try many, many of them. We try the nasopharyngeal swab, the stool swab, and then when it comes to, like I said, sometimes I said do a biopsy, and that's the way we're going to find it. So I have to run that specimen back to my lab, and we'll look at it, and most of the time we find it. With a neutralizing antibody, we can do the acute and convalescent titers. So, but that you won't get that results back for a while because that laboratory is so busy. The test probably won't come back for 10 to 14 days. They actually have to set the plate up with viruses on a cell monolayer. Then they put mix the antibody in to see if they can neutralize the virus. So it does take time to to form plaques and all these things like that. So anyway, yeah, this is still one of the biggest problems. But the problem, I went to this conference in Europe every couple of years, and this is one of the best RNA virus meetings on coronavirus, enteroviruses. People talk about what happens to these viruses when you grow them outside the body. Nobody talks about them when they're in the body. No one spent any time or energy to look for these viruses in the body because they don't see patients. That's the disconnect.
I get it.
Yeah.
Yes, that's a disconnect in so many other pathogens as well, and other things
absolutely.
where the clinicians are too far separated from the scientists, and they're not necessarily drawing from the actual clinical experience of the MDs to study topics that are most relevant to the actual patient. Yeah, that's really interesting, John. And so then you actually done quite a bit of formal research where you have showed that in patients with an ME/CFS diagnosis that you have gotten these gut tissue samples that you obtained via endoscopy, then you've not only identified the enterovirus in the majority of those via PCR for the RNA, but also you can find the antigen, correct? And also, like you said, you can sometimes even culture the virus out of the sample, correct? And then you've done also autopsy work as well, correct? Where you've looked at the brain of patients.
Right. So the first part of this, once we can see the antibody, we have to convince other people the virus is still there because everyone can just say, oh, how do you know? Just everybody, just have these type of antibodies. Well, we're already proven that's not correct. People are skeptics. They don't want to believe something. They won't believe it. So all these years, I've been telling people the evidence, and then everybody else, somebody will just say, well, you have to replicate these findings. Come on. Other people have done this before, all right? I'm not the first one who's shown it. I just look for a different place. Other people have done muscle biopsies. They have looked into the brain. They have looked into the heart. I just happen to find a place. I know if a virus starts the primary infection there, if they can be persistent, we should be able to find it there. And that's exactly what came through. So we find the viral protein in 83% of the stomach biopsies, which has become true after we've done 850 specimens. The viral RNA, probably about a third on the best days. It's really hard to find these because I think the RNA are really bound to the proteins, because that's one thing that, the cellular response is they will have helicase and all these proteins they'll hook up to these RNA and somehow they're locked up. It's not really easy to find them. So we find them there, and then we can put it into the culture, and we grew out non-cytopathic, that the viruses don't kill the cells they live in, but we can pass it to another set of cells and they get infected in some of the samples. And so, that was the first paper we published in January 2008. I presented at the CFS meeting in 2007. Dr. Komarov put his hands up at the end and said, well, maybe it's enterovirus. Okay. Well, then nobody else repeated it. Okay. Then it's like, oh, okay, well, then, let's move on to something else. Let's look at psychological parameters. This is the problem. Okay. So then we look at all that. I said, is this convincing enough? I said, why can't we infect cells with it? So why don't we see if we can take the stomach biopsies and inject into the mice? And these mice are immunocompromised. They're SCID mice with severe combined immune deficiency. They don't have T cells, they don't have B cells. So we injected these samples into these mice, and we also boil some samples. We're not so sophisticated in eliminating the RNA. So we boil the samples and we inject in another set of mice. So 70% of the mice got infected by positive tissue staining of the spleen, for instance, their lungs, the heart, etc. And 2 of them died in 2 weeks. And both of these mice who got stomach biopsy samples from these 2 patients actually have Coxsackie B3 infection. There's sky-high antibody levels in the blood. Coxsackie B3 is actually the most common cause of myocarditis in the world. So eventually, when we did in vitro hybridization, we saw the viral RNA in the heart. That's like everything took us, a couple of years before we figured out how to do it. We had to do all these things many, many times, but eventually that's what we found. That's so amazing. Then after that, I said, well, we've proven this can persist in there. And then one of the patients that actually committed suicide, and that was over 12 years ago. We worked on that brain for that long. And eventually we figured out that the neurons are infected. We can see the viral protein in the neurons. We can see, some of the neurons undergoing apoptosis. Some of them just plain dead. And it's really amazing. And then we figured out by doing the RNAs of the weapon system. I mean, people will do something like the cytokine arrays and all that. We don't have the resources to do that. But we looked at the toll-like receptors, which every cell has as a weapon. You turn the toll-like receptors, then it will trigger the interferon gene. And then we saw the gene was upregulated at the meeting. I showed you it was the most bright area is the cerebellum. That's where we saw the most infections. Cerebellum has the most neurons, actually, the Purkinje cells, as compared to the rest of the entire brain. And many of those have dropped out. They have died. Okay, so we saw that. Then we can sustainable interferon in the cell body. I mean, what else is it? We have this patient that had acute. So someone asked me about is it cause or or association, right? Well, I presented this whole case from the very beginning. Remember, he went to Japan to teach English, and he got sick. He came back. He had a very markedly elevated echovirus 11 antibody. I did an IgM test using a research lab tool. He was positive, more positive than the positive control, actually. All right. Then we treated him with interferons. Then 5 months later, 5 months after he got sick, and he's still vomiting, he's still really sick. So we did the endoscopy and the colonoscopy. We found the virus in the stomach and in the colon. Later on, we found the double-strand RNA in the stomach. So no doubt that he had an acute infection. that persisted up to 5 months. I always told his father, this is a brain infection. We found in your stomach because we can't get to the brain. So when he committed suicide, the dad called me and asked me if I wanted the brain. He went to get his son's brain. Okay, this is his only son. He's almost like 70 years old. The young man was almost 30. This is sad. Okay, but he gave us a chance to figure this out.
Yes.
Yeah.
Yeah. Yes. It's a really interesting series of events, John. I mean, so in other words, you've shown that enterovirus can be found, and the protein that it creates can be found in a large proportion of stomach biopsy samples from patients with an ME/CFS diagnosis. You've also shown that you can take a patient who seems ill in an acute stage of the disease and follow them and show on repeated occasions that they still harbor the virus over longer periods of time, correct? And also, you've taken virus from some of these patients, put them in the virus into mice, immunocompromised mice, where it has succeeded in causing disease. And last, you actually were able to obtain the brain from a patient who had enterovirus issues that you knew were already occurring in the gut, and you were able to verify the presence of the virus in the brain with a preference for neurons and cerebellum. So in other words, like quite a bit of evidence for these processes. And then, when you mentioned that the gut, in a sense, can be a reservoir, and then the virus also gets into the brain, would that be via vagus nerve? How do you think that the virus gets from the gut into the brain?
I think that's really important to point out. You asked me that question at the meeting. Well, from the work on enterovirus 71, and which is a big problem in Southeast Asia. Well, ironically, the virus originated in California, and it's a devastating disease. And usually the children will develop myocarditis and also brainstem encephalitis in the back of the brain. And they usually die from respiratory failure and cardiac arrest. And one epidemic, I think 600 little kids died. So over that area, they really have a tremendous interest in this virus, and it can cause chronic diseases. People really look into, what happened to these patients who survived one of these severe cases of encephalitis. What happened to them? They have chronic cognitive dysfunction. The people just don't use this term fatigue. If you ask them, are you fatigued? I can guarantee you every one of them is fatigued, right? Yeah. So, but from that work, they actually did experiments. They actually orally fed the enterovirus 71 into the mice. And then they either have a set of mice, they just kind of let them do their thing. And the other one, they actually clamped the vagus nerve. So the virus cannot go up the vagus nerve. And lo and behold, the one that didn't clamp the vagus nerve, the virus got into the brainstem. And the other one, nothing happened. But from a lot of work elsewhere, we actually read a basic science. Like in cows, this vagus nerve is used from, let's say, bacteria like listeria. They will migrate up into the brain. And listeria is a big bacteria. Virus is tiny, and it will go up by what we call retrograde or axonal transport. And they just have this thing. They just know how to do this. Well, every time I think about this, then I said, well, how does rabies virus know to go into the brain from, let's say, a leg injury? It find a little twig in the nerve, get into the bigger nerve, go through the spinal cord, eventually migrates all the way up to the brain, and then kill the neurons. This is what they do.
Yep.
Everybody work with enteroviruses is neurotropic. Yes. It loves the brain tissues. It loves the brain spinal cords. But the problem is when people do certain type of studies, they really misinterpreted the results. And I'm not going to mention the institution names. So we have diseases like ALS, sadly, which there have been some solid evidence these viruses get into the motor neurons and eventually kill the patient within probably less than 2 years. Okay, I have a tremendous interest in that too. Once we have a drug, that's going to make a difference. Yeah. I think, because otherwise, what do? You tell a patient, well, you go home and you're going to die within 2 years. right? That's not
Yeah.
acceptable. This
No, it's not.
disease, the myalgic encephalomyelitis, patient just keeps suffering. I mean, we have
Yeah.
patients been bedridden in a dark room for more than 21, 25 years. They just lie there. They can't listen to radio. They can't watch TV because every stimulus makes them so ill. And we have these patients come in. I just see them cry. I said, I have to be able to get them there.
Yes.
That's my impetus. My son is well now, thank God.
Wow.
Okay, yeah.
Yes. I mean, yes, and it really speaks to the fact that we need to do more autopsy work on these patients. I've definitely struggled because, for example, right now, there's no ME/CFS brains in any neurobiobank network right now. There's actually, I think, maybe 2 or 3 in the US, but they have Alzheimer's comorbidities, which is really hard. It's very hard to dissect that. In other words, if we were to study those brains, we've already been told that a lot of people would interpret whatever we found as part of the Alzheimer's disease process. So we're trying to work with a group called the Brain Donor Project with other organizations to help people register their brains so that we could get more over time to be able to study these trends. I think that's one of the reasons of many, and some reasons are actually just hard to understand that this topic isn't better acknowledged in ME/CFS is because you can't do a simple blood test. You can't take a patient and show that this is happening. You have to actually be able to get into the central nervous system, which is impossible to do in a living patient. So that becomes at least one of the obstacles, although there are many. Although the way that you obtained stomach biopsy samples was a really good way to get around that. I think so that ability to understand that you can get the stomach sample is very cool. But with that, I guess when you treat for enterovirus, what do you do? What did you do to help your son?
Okay. Well, when I first diagnosed my son in 1999, and I once we found the positive antibody tests, I looked up, what the British guys were doing, and I said, I read their papers. I said, they couldn't be lying about their findings. I said, one study actually did RNA testing on 400 samples, blinded samples, 200 patients, 200 controls. They found it in 39% of the patients and 2% of the controls, and blinded samples. So they couldn't lie about this, right? And they were just good at what they do. And we Americans never repeated it. Well, the guy at the NIH actually was one of my teachers a couple of times in the 2 years of fellowship. He sent the samples to the guy in Denver, and they tested the plasma. Okay, well, this isn't in the plasma; it's in the white blood cell. Viruses live in the cells, right? This is not HIV. We're lucky that HIV we can find in the blood. So that field moved on in 1984 because 2 investigators found HIV in the same tube of blood, replication, right? And it was killing the T cells, which was growing it. But this was much more difficult. But after 10 years of time, and then people say, okay, well, we can't find it, therefore there's no virus. It's not quite like that. The way I always tell my patients is Mars is too far. We can't get there. Therefore, Mars doesn't exist. It doesn't work like that. We have, because the patient has symptoms. That's the most sensitive information. The patient tells you what's going on with these guys in their body. And if we don't look harder, then we did them wrong. Okay. So that's why we keep pursuing it. Whenever we have a chance, we get a sample, we look for it. Let's say patients who have chronic pelvic pain, which is quite common in this disease. Usually, women unfortunately have much more of this stuff because, well, people can all get sick as a youngster. When you get a virus, you can disseminate, and then you think it's all over, right?
Yep.
Okay, then by puberty, women oftentimes will start having migraine headaches, right? That's very, very common. That means to me, the virus is already gone into the brain.
Wow.
And people will say, oh, how do you prove that? Oh, yeah. So we're going to do an autopsy on 100 brains. This is, you have to use these examples, okay, to figure this out. And the women will start having pelvic pain before they menstruate. they'll have horrible, horrible pains,
Yes.
either one side, both sides, right? So how many years later, well, they were found to have endometriosis, right?
Yes.
Endometriosis is the fallopian tubes not functioning at the end when it's attached to the uterus. So when the menstrual blood comes through, it just went backwards through the tube and dropped into the pelvic cavity. That's what called endometriosis, right? And so why does that happen in the first place? So we have done 30 plus fallopian tube samples on
Wow.
patients with pelvic pain, and we've done controls too. Well, one of the things about patients with pelvic pain, oftentimes one-sided. So the other side can be a control.
Yes.
We can see the viral protein in the fallopian tube 90% of the time, and not the other side.
Wow.
And we take in one of these tubes, we got it fresh, inject into the mice. These are female mice, one female mouse, okay?
Mm-hmm.
The fallopian tube and the uterus got infected. That's what they do. They know what they do. I mean, this is something that everyone has underestimated. People don't understand these viruses, therefore they don't exist. It doesn't work like that. You look how smart they are.
They are smart. John, that is fascinating with the fallopian tube data. I definitely am very interested in the role of infection in endometriosis. It seems obvious at this point, to be honest, which is a topic we're also somewhat trying to work on. Now, I have a question. Do you think that that enterovirus can infect the peripheral nerves? For example, many of these patients have small fiber neuropathy. Do you think there can be an enterovirus component to that?
Yep. I don't know about small fiber neuropathy.
Mm-hmm.
I always have to ask the question, where's the origin of that cell body, the nerve
Right.
cell body? Is
Yeah.
it really in the periphery or is it up higher, right?
Yes.
But these viruses are known to cause epidemic neuropathies. It's been described in either Wyoming or the other state, big state, Montana. So, like in a village, a whole bunch of people came down with this epidemic neuropathy or epidemic vertigo. These viruses can do that. Remember, they go to the spinal cord. They can cause peripheral nerve disease, usually the cell body. We have seen brachial plexus disease. Actually, a doctor who came to me after I gave a lecture at Cedars-Sinai Medical Center, I was telling them about all these interesting cases I've seen over the previous decades. He came up to me and he showed me his hands and his arm. I said, "You must have brachial plexus injury." And he said, "Yes, this happened after I went to Lake Tahoe." And he said it happened that a couple of other people had it too.
Wow.
Is that interesting? You tell me.
Very interesting. Yes.
They didn't hurt themselves. I mean, everybody just ignored these guys. Yeah.
Wow. Interesting, John. In other words, so with the peripheral neuropathy, what you think is that it's actually the nerve body in the spinal cord that's connected to the peripheral nerves that is most likely to be infected.
That's right.
Okay.
Because the virus has to live inside the cell. It's not quite like the demyelinating disease, where you have, may have autoantibody against myelin, then you cause the demyelinating of disease. So I think it's still in the cell body. So that's why I was mentioning, the projects. So, you really have to look for the cell body, because if they're damaged and they stay positive for the virus, absolutely, that's absolutely true. Yeah.
Yeah. Wow. Interesting. Wow. Okay, well, going back to treatment then, you have a supplement you helped develop called Equilibrium, correct? And then actually more recently, and I'm not sure, I think it's some cases, if you've been using remdesivir actually on some patients with ME/CFS?
Yeah, so from the very beginning, we realized we're onto something. But the problem is there isn't a good drug yet. I went to the drug companies and I talked to them. In 2005, I wrote the first paper in Journal of Clinical Pathology called The Role of Enterovirus in Chronic Fatigue Syndrome. At the very end, I talk about three things. Number one, we need to have a cell-associated RNA assay, a reliable one, so we can diagnose patients. That's still elusive. I'm not even sure that's possible. I think it's not going to be sensitive and reproducible enough to diagnose a patient. We have our protein. We're working on that. And then I said the second thing was to do a controlled trial with alpha and gamma interferon. And we already done that. We didn't do a control study. Nobody wants to fund it and all this. We can see this type of stuff work. We published some of the results already in obscure journals, since none of the mainstream journals and those critical reviewers want to even hear about this. When I sent in the paper on these type of treatments, and the 2 or 3 of the reviewers said, chronic fatigue syndrome is a psychiatric disease. Why are you treating them with interferon? Yeah, am I going to say idiots or what? Right? So anyway, so we did that. And then the third thing I said, we need to make these RNA enzyme inhibitors, RNA polymerase inhibitors, just like what we have for hepatitis C, right? I mean, you see what tremendous, results we had with those drugs. But hepatitis C until 1991 or 1992 was known as non-A, non-B. And they didn't know what it was. They knew it was a transmissible agent. It caused hepatitis, right? Some people die from it. But one group, one of the drug company in Northern California, went after it and cloned it. They developed technology that had benefited all the people that were looking for viruses in the blood. And they figured that one out. They call it hepatitis C. Then from that point, 1995, we had the interferon and ribavirin treatment. And look at when we started using the more targeted drug therapy, probably about 5, 6 years ago. It's a long time. So at that time, when my son got sick, I said, what do I do for him now? I actually gave him a couple of medicines that we use for HIV, because HIV multiplies the RNA. The RNA gets reversely transcribed into a DNA, gets inserted into the chromosome, then that gets replicated into RNA. And lo and behold, when my son took this very safe drug called Epivir or lamivudine, which I still use nowadays, you really are desperate. And his cognitive dysfunction totally resolved in 3 weeks. He was able to read my psychiatry book on depression. He read 25 pages in depression in 2 hours. It would take me 2 days to read that 25 pages. And he couldn't stop telling me what depression is all about for 45 minutes. And until I said, okay, enough now. I said, you learned this subject. Then I realized at that time, this disease is treatable. That's 1999. This is 2021. Anybody listen? 2006, I went to a drug company. I talked to them about making us one of these drugs for the RNA. It's an RNA polymerase inhibitor. They loved what I told them. But in a year time, they totally forgot about me. Eventually, now we have better drugs now because of COVID, right?
Yeah.
Well, over the years, we used IVIG, we use interferons, and IVIG is just a big band-aid. It kind of ameliorate the inflammatory response. So patient feel better. The response rate is not that high. It's no greater than 30%. And it's so expensive, the insurance company would not like to pay for it. So, and people have to have hypogammaglobulinemia, and they don't respond to certain type of bacterial antigen, like the pneumococcal antigen, in order to qualify for it. It's very, very difficult to get it approved by the insurance. Sometimes we had to fight to the state level.
Yeah.
Interferons, we use less and less now because, first of all, it's so expensive. At the time that we were doing it, we actually had samples. And people were using one of the drugs for hepatitis C. And the other drug, luckily, some of the patient could have to boost up the immune system. So now we use, the herbs. One of the simple herbs is called dihydroquercetin. Dihydroquercetin does have activity against Coxsackie B4 in the culture, demonstrated by the Russians. So that, one preparation is called Russian rejuvenator. It has a modest activity. It's very simple to take, very little side effect. And some patients who took it, especially with the Coxsackie B4, the POTS totally resolved within a month. Yeah, the really severe POTS just totally resolved. Yep. And it kind of means something, doesn't it? It also stabilized the mast cells, which you hear people talk about. All those are parts of a puzzle. My attending that taught me the first case of Coxsackie myocarditis, he often told me, don't miss the forest for the trees. That has been with me all these years. You got to take a few steps back. Anytime you start kind of getting too close to something, move back and think of a big picture.
Yep.
There's something much bigger here. All right. So then we use Chinese herb, equilibrium, for instance. Initially, we use oxynitrine from China. We have given that to, I don't know, maybe 1,800, 2,000 patients now. It works anywhere from 30 to 50%. It can be very, very effective. But when for patients with a lot of neurological symptoms, really bad neurological symptoms, and have neurological findings, like they cross their eyes, they see double, and those, that neuro-ophthalmologist would say that's psychological. Can you believe it? This is how they get treated. Psychological. You cross your eyes like that, psychological. It should be started very slow, maybe 1/8 of a tablet with food, a couple of weeks, then you go 1/4.
Yeah.
And for 2 weeks, then you slowly move up until you can tolerate it. Sometimes it would take 6 months to get to 1 twice a day.
Right.
So more recently, it's not exactly serendipity, but because patients are coming into the hospital with COVID, and I had to see them. I see a few hundred now. So, and so some patients have a background of, say, fibromyalgia or chronic fatigue syndrome. And they came in, they looked so sick, and they got this. And I said, well, I'm going to give you this medication. We'll see if this should help the COVID infection, but maybe this will help some other things. So the very first patient I presented at the meeting, that person became a normal person for a month, which has never been like that for 8 years. She's a single mom with 2 children. She had to work 40 hours a week, sitting on the computer. She had brain fog all the time. She felt terrible, body aches. If she doesn't have to work, she will not work, right?
Yeah.
For that month, she went out to do everything under the sun. She's never had a single day like that in 8 years.
Wow. And you're talking about remdesivir, right?
Remdesivir.
Okay.
Right.
Yeah.
So this is the first one. The second one, who's been sick, I also presented at a meeting. This young patient got sick at age 17 and with pancreatitis. And this thing never left her. So every month she'll be in the hospital for like a week, 3 weeks. I think I presented this at the time. Every time she ate a large meal or just a regular meal, she'll start vomiting, have abdominal pain that will last that long. I mean, if you eat something wrong, maybe you'd be sick for a day. I mean, this is her disease. So I know her for 15 years. She had Kawasaki before, which I told her she had, and the test showed it, because Kawasaki before is the one that goes to the pancreas. And it has been highly associated with type 1 diabetes also. It depends on which cell it hits, okay? It's either the exocrine cells or actually the islet cells, right? Okay, so anyway, and eventually she came to the hospital with COVID. She was crying because she already had a kidney transplant 7 years ago for a kidney failure. And she said, I'm going to die now. I said, this might be a blessing in disguise. So I gave her this medication over 5 days worth of supply over 6 days, because she's a smaller woman with a little bit more of her steroids. She's already taking that to prevent rejection of her kidneys. After 4 days, she felt dramatically better. And she that's from COVID. She said, oh, I have to eat. I haven't eaten for a whole year. She gets intravenous nutrition, right? And so then she started vomiting and she had abdominal pain for 5 weeks. She stayed in the hospital for that long. That's very much her though. She's like that often. But the interesting thing is, like, the people with this illness, they do too much. They think too much. They get so tired, right?
Yeah.
A pancreas, it doesn't get active until you eat. So when she ate, she actually turned on the pancreas. So the virus infection in the cells become active. They're having a party too, right? But there's one difference. The antiviral drug is circulating in her blood. Then we have bang, bang, bang. We hit a few, maybe. Then it generated this immune response. Then she started vomiting. So 5 weeks later, she came out. She went to another hospital and they replaced her pancreatic duct stent, which they've been doing for every 4 months anyway. It hasn't changed the natural history of this disease, but they believe she's better or she's not better. She came out, she said, I can't believe I feel so good. She started eating 3 full meals a day for the next 3.5 months without a problem. Wow. This has never happened in 20 years. Okay, this didn't happen by chance. Her brain fog lifted. She's not tired. She doesn't have body aches anymore. She finished 2 classes online. in 2 months. And beforehand, she couldn't finish one class in 3 months. So she basically gave up. So her cognitive dysfunction actually got better. Then about 4 months later, she had the stent changed again. She relapsed. At this point, she said to me, she's still better than before. Okay. And I show at the meeting that I can see the viral protein drop, right? Over the 5 months.
Okay.
It took a long time for it to go away, but it did go away. Okay. But we still, just based on her symptoms, you can tell still there are enough cells in the pancreas or in the brain are still infected. There's still residual infection. So what if she gets longer treatment? I talked to her about this last week, and we have to somehow figure out some way to do this. The third patient did not improve because she was getting interferon treatments to prevent her going back into the hospital. She was in and out of the hospital for 6 years because of the Coxsackie B infection. And so with the interferon treatment, she was out of the hospital for 2 years. Then she caught COVID and came to the hospital. I gave her the remdesivir. They actually counteract each other. The viral protein actually increased in those 5 days I gave her the treatment. So I don't know anybody actually got that message. Everybody's in a hurry to have me stop, right?
Yeah.
Remember that?
Yeah.
They didn't get how important this was. That was disappointing.
Yeah.
For our infection section, we did not have a proper moderator. I don't mind say this on record, okay?
That's fine. Yes.
Okay.
I agree that you were presenting very important, compelling data, and it was somewhat interrupted and not clarified. Yeah. I agree. That's part of why I wanted to interview you right now. I mean, I got it's 2 cases, but that's compelling pilot data and very interesting. And I suppose the ability to continue to study that will depend a bit on how remdesivir will be, whether or not it may be allowed to be used for other diagnoses, whether or not it could be administered outside of a hospital setting. I guess we'll see how that progresses.
Yeah, that is what we're kind of waiting for right now. The other good news is that there is going to be an oral remdesivir preparation.
That is incredible.
They are studying that in the early COVID cases, just like you heard about the Merck drug,
right?
Nuprevir, that got a lot of attention lately, and so it's going through the FDA now. It may get approved by the end of November. Yeah, remdesivir, when it's given for like 3 doses in the early cases of COVID, completely prevented complications. Absolutely, no one. Yeah, no
it
one
makes more sense to give remdesivir early, honestly, based on its mechanism. So I really hope they really do that with the pill form that could be administered early. That would make a lot of sense. I think there's a feline version of remdesivir already in a pill form. I'm not sure.
I don't know.
I've been told that. But I'm not sure. If that's the case, well, or it's something similar enough that it again, like you're saying, it suggests it could be made into pill form, which would be very interesting. But definitely gives me some hope in terms of, I guess, COVID and SARS-CoV-2 has now increased interest in developing antivirals for RNA viruses, and that's one upside of the pandemic, possibly. So that is very interesting. Separately with SARS-CoV-2 itself, do you think that SARS-CoV-2 is also capable of persistence and also sometimes infecting tissue or nerve in these patients as well in a chronic capacity? Because there have been several studies that suggest that's possible as well.
Well, I think so, but I really haven't done much work with this because I only seen one patient with post-COVID long hauler syndrome. But in reality, so you have to drill the patients and ask them detailed questions in order to know if it's COVID or maybe something else that started already. Yeah. So this 53-year-old pediatric nurse came to see me. She got COVID last year. She's devastated, couldn't hardly do anything, but now she's better, maybe after about a year and a half. But at the year time, then she came in and she has 4 blood test results that shows 4 enteroviruses antibody in her blood. And she has IgG subclass 1 deficiency. That's the most important antibody to neutralize enterovirus.
Yes.
So it's like, maybe you have something, right?
Right.
She said, no, I have never had an infection. I said, you're a pediatric nurse. You take care of kids with viral infection most of the time. You never got an infection? She said, no. I looked at her, I said, look at me in the eyes and tell me you never had a viral infection. And she said, oh, I remember now, I had encephalitis at age 3 months.
Okay.
Well, that
Right.
gave it away, didn't it? She was
Yes.
hospitalized. I don't think that virus ever left her. But then when
Very
COVID showed up, I
There you
think
go.
the virus got reactivated. Just
Yes.
like people are talking about, those are called associations. Okay, like people are saying, oh, this last year, the diagnosis of Alzheimer's disease has skyrocketed. Right. So people get exposed to COVID, your body fights it. You kill off the neurons.
Yeah.
How do you know those neurons are not chronically infected, like I showed at the meeting?
Exactly.
So don't think a new infection is got to be what it is. That's why I asked Dr. Nath. I said, did you do immunoperoxidase and also in situ hybridizations on that brain that he showed was the post-COVID case?
Right.
He was showing the white blood cells around the blood vessels, et cetera. And he said, we did. And then he said, we didn't find it. Then it's not the same because I showed it in my brain, the enterovirus protein is there, right? We show the RNAs there. That's
Right.
for sure that. But I will be interested in working at that brain and see what we find.
Right. In other words, not just looking for just SARS-CoV-2, but other neurotropic pathogens that could have already been infecting the patients that simply had an opportunity to cause more problems in simple terms because the patient got COVID. And in simple terms, the immune system got distracted or dysregulated from COVID, and that allowed the other infection to become more active or prominent, right? I mean, yeah, Mike Van Elseker, my colleague, we wrote a paper on long COVID, and we put out a couple different scenarios for the disease process. The first one is just that maybe SARS-CoV-2 itself doesn't clear, which could be the case in some patients. But the second scenario is that, yes, it creates an atmosphere in which other already harbored pathogens like enterovirus, or perhaps in some patients, Borrelia, Bartonella, depending on what they've been exposed to, even another herpes virus such as Epstein virus could themselves become more active and problematic in and of their own right. So in other words, the COVID disease allows the other infections to become more overt, I guess. So that
I think, yeah, both theories are possible. I certainly believe COVID is smart enough to get into the neurons, is known to infect the neurons and the glial cells. And anytime they can get in, and there's pressure from the immune system, for instance, interferon production, and you produce RNA cell, and you can actually, we don't know if they can form double-strand RNA, but this is a positive strand RNA, just like antivirus is a positive strand RNA. Can they form a double-strand RNA and then just persist there like the seeds of the weeds, right? Yeah. We all think weeds are gone when we put them, and then they will come right back. So, but interesting story, in the beginning of the epidemic, we used hydroxychloroquine, right? Because there were nothing better, and steroids. And some of the patients, hydroxychloroquine does not get into the brain. So a number of the patients develop horrible brain infections. One of them actually developed this almost like ADEM, acute demyelinating encephalomyelitis. The entire top of the brain was white on an MRI scan. And he obviously passed away. And we saw other patients with stroke-like pictures, but not from the thrombosis of the blood vessels. So I think it's entirely possible they can be there. Interestingly, remdesivir treated patients. We have never seen one of them develop neurological problems, as far as I know.
Interesting.
All the ones I've seen, that drug gets into the brain.
Wow.
25% of the drug gets into spinal fluid.
Wow.
Yeah, because one Chinese study actually did a spinal tap while the patient was getting it. I don't know exactly what they're measuring, or they just want to see what gets in. 25% of it can be measured in the spinal fluid. That's remarkable.
That's remarkable.
That's good news for us. Yeah.
Yeah, it's interesting because there's some debate now on whether or not SARS-CoV-2 can infect the brain, which is strange. And there's a German neuropathology team that did a really good study where they looked at a lot of different brain sections, brainstem, even vagus, actually. And they found either SARS-CoV-2 RNA or antigen in the many areas, olfactory bulb as well. And then a couple other teams have not found the RNA or antigen, although they didn't do as many sections, or they found just the RNA. I mean, but overall, there's very little reporting on whether or not the patient before they unfortunately passed away was given remdesivir, or how they were treated. So I think, part of better understanding some of the differences in the autopsy findings is actually understanding. It's really interesting to know that you think remdesivir may prevent the virus from entering the brain, because I haven't heard that before.
It just may, because we
Right.
of course we don't have the
No,
correlation. I mean, we certainly have patients that are treated with remdesivir and passed away from the severe
Yeah.
lung disease.
Yeah.
And but many of them, when they were awake, they were fully awake.
It's
Their mental
interesting.
status is clear. And
Yeah.
but this whole thing about these viruses get into the olfactory nerve and then into the brain. I mean, the olfactory bulb ends right underneath the temporal lobe.
Yep.
Once they get in, they can go anywhere they want, right? So the temporal lobe, the frontal lobe, in the middle of the brain, they can spread so rapidly. But people didn't know was Kawasaki B can do that too. It's
Yeah.
known before.
Exactly.
Yeah. And
No.
influenza virus, herpes virus can do all this. So they have a way of finding it. So, but anyway, I think the more research is needed, and just from the brain study, I can tell you, we spent 12 years doing that. It's very hard we had to keep repeating the experiments.
Yes.
Because sometimes you see it, sometimes you don't. Because it's not like if there's like 1 million viruses there, it's a no-brainer, right?
Right.
But there's sometimes just in one section, microns, you don't see it. You cut a couple more, you'll see it. It's like that.
Yes. That is a huge issue for pathogen research, other persistent pathogens as well, is the low biomass nature of the infection. Like you're saying, you have this challenge, again, I'll repeat, where the patient, the body fluids, blood, urine are not easily tested or cannot be tested well for the pathogen. Then you have to move into tissue. Even when you get a tissue sample, the persistent virus or pathogen is present in such low amounts that you may not even find it in some of the tissue samples. You need multiple tissue samples. Then it depends on how the samples were collected, if they were preserved. Sometimes there are teams that don't stabilize. I'm not sure, I know that when you collect samples, you try to put them in RNA shield, or you try to snap freeze, to preserve the RNA. But there's also some consideration where teams don't do that. And then after a while, they look at tissue and then they don't necessarily find RNA, but RNA can degrade rapidly. So depending on the tissue type, that's another important consideration. So in other words, you really have to understand, it's almost like you have to be a detective and you have to understand the characteristics. First, you have to understand the pathogen you're trying to look for. Where is it likely to be? Is it neurotrophic? Okay, then we should look in the nervous system. Where what is it, when it sticks around, where would it be? It would be in low levels. It would be here, So with that, within those contexts, you have to exactly be able to understand the limitations of your methods. And I think that's going to be one of the biggest things going forward. Is I know a growing number of teams that want to study enterovirus involvement in ME/CFS and even in related diagnoses. But we need to have more meetings and more discussions about optimal methods and optimal techniques for finding these viruses. And we're definitely trying to do some of those. And we're definitely also trying to do some enterovirus work with the team at the Joint Genome Institute in Berkeley that you may provide some sample for. But we are also iterating so many parts of this. It's going to take us a really long time to be confident in the extraction methods we use, in what we're doing, in our ability to know that we're doing it right, and even also to get the samples. So yeah, I think, that would probably be then my last question for you is, for younger or whatever, any researcher that wants to continue the line of work that you're doing or join in, I would say, and also research this topic, what advice do you have? You've alluded to many things already, but if you could leave with some of your most clear advice on studying this trend, what would it be?
Well, it depends. I mean, enteroviruses, I think one of the easiest places to find them is actually the stomach, because either if you have a respiratory infection, you still see, you will swallow the secretion into your stomach, or you swallow the virus from the food or the water, right? And it goes into the stomach. You just turn out the stomach is a reservoir, and the food and all that stuff have to churn there for a while, and the virus find the place to live. And so it's actually a very easy place to look for this. There was a professor in Georgetown, a pathologist, who actually did some of the work I've done. He actually was doing it for a different foundation, and he showed the same thing I did, but he never published it. So it's not that I've never been replicated.
Mm.
No, this is it's been done. So if you want to do that, that's fine. But stomach biopsy is a little tedious. It's like, but it all depends on the patients. So if there's anything else that we can do to optimize the diagnosis, that's why we're working on the viral protein and all this stuff. And we may be heading somewhere. So that's what we're hoping for. But we have all the background data now. You listen to the patients. That's the most important thing. You get the history from the patient. How did they get sick? When and what? Okay. And one of the most important thing about enteroviruses is that it doesn't go away, or it recurs. Like people get sick for 2 weeks, they get flu-like symptoms, and then somewhere along the line, it could be a few days and a few weeks that they start having the same symptoms, or the fatigue usually doesn't start that quickly. Sometimes the fatigue will start 6 months later. Because when patients get a respiratory infection, the virus goes up the vagus the olfactory nerve into the brain. While you're fighting the respiratory tract, the virus in the brain doesn't show up. Once you kind of fight the virus down in the respiratory tract, then the brain will show up later. So what they have 6 months later is exactly what they had before. It's just in a different area. That's why there's this confusion about, oh, there's no flu-like illness before. You have to kind of count flu-like illness within the previous 6 months, okay? And to see, and I hear this pattern quite often, as patients swim in the lake.
Yes.
And we actually have a number of patients now that come back and told me that, oh, I was in Lake Tahoe in 1983, 84, I was in the water. Wow. And they got sick.
Interesting. John, have you ever thought about, and it might be a funding issue, going back to some of the patients who are still at Lake Tahoe, who are still part of that outbreak, and trying to get
I approached Dr. Peterson regarding this just 6 months ago. Then the third wave of COVID hit, so we kind of lost communication. Then I sent back an email. It's up to them because he's collaborating with other investigators.
Right.
If they are capable of finding it, I'm entirely happy because other people can find it. You actually reproduce my results, my thinking, right?
Right.
If I keep doing this and people say, well, this guy's biased, he must be somehow doing crazy things. I'm pretty sure that was an enterovirus infection. It's just not one of the 11 because we have several patients we've seen from those days. They don't have neutralizing antibody against the 11 viruses, but they have positive stomach biopsies or they have antibodies. So one of these days when I get to it, I have to write them up.
Okay.
But, we're so busy seeing patients, take care of them. You may not know this, but in 1979, 1980, when we saw the AIDS patients, every single patient took half an hour, 45 minutes. Everyone had a fever, had a headache. There's so many things that can kill them that we had to spend so much time scrutinize the data, examining them, talk to them, and all this. Now we have 42 plus drugs now. It takes 5 minutes to take care of those patients.
Wow.
They're not sick anymore. That day will come for us. But so all these years, since 2005, 2006, I said an antiviral drug will help us. That's what we're looking forward to.
Yeah. I mean, it really is. And last thing, and I will let you go, is you alluded to it before, but one of the things that I think has maybe added some confusion to the topic of persistent infection in ME/CFS, which seems very straightforward to me, is that there have been a couple other teams. For example, I have interviewed Dharma Blashi, who's done work with the HHV6 virus. So there have been patients who obviously have higher titers of Epstein-Barr virus or whatnot. Do you think, like you mentioned, I just want to reiterate it, that it doesn't have to be, you could have a patient who has an HHV6 infection, human herpes virus 6, and an enterovirus infection. And in a sense, that might actually be in a sense, a normal thing, and that the herpes virus could downregulate T cell responses, like you say, and perhaps allow the enterovirus to better survive and drive its own sets of symptoms as well. In other words, do you think that's possible? that there could be multiple viruses involved in some cases, with enteroviruses being the central ones, but the other ones being players as well?
Well, the most relevant example of this would be the HIV/AIDS patients,
Yeah,
right? If you take their blood tests, Epstein-Barr virus, CMV, well, at that
exactly.
time when we started having the epidemic, HHV6 didn't exist yet, not until 1991, I
Right.
believe. So all their antibody tests were high, but they didn't play a role in the disease, not until the T cell counts are really low and the patient are dying from AIDS, and then B cell Epstein-Barr virus can transform into a B cell lymphoma, oftentimes in the brain, and kill the patient. CMV would develop, disseminated disease in the eye, in the lungs, in the colon, et cetera. And we know this because that's called a disease. Just having an antibody test or a positive DNA, especially it's a cell-associated DNA, doesn't mean anything. But Dr. Montoya has told us when he was running the bone marrow transplant before, and they have these patients that get bone marrow transplanted and they spike a fever. And they will do all these gene tests to look for CMV, for Epstein-Barr and HHV6. And the HHV6 DNA will be positive in the plasma. Now that's real. He treated those with Valcite or Valganciclovir, and they effervesced, they improve. That's called real disease. But see, the whole problem is when we have intact immune system, okay, these viruses are, they're always reactivated. So let's say if you go to Costco and take the saliva of 100 people, you can 30% of them you can probably find herpes 1, Epstein-Barr virus, DNA easily. They don't have symptoms, but they're constantly reactivated in nasopharyngeal tissue, right? So you have to scrutinize all the studies in the past, because there was a study on identical twins, discordant for the ME/CFS. One had one. Remember this, the Seattle study.
I do.
And, I'm sorry.
Oh, no, I think I know.
You didn't read the study, right? And I wrote a letter to them. When I read, so I basically pointed out they use type of testing you could see in normal people, so you can't really tell who's sick and who is not sick. I said, you're measuring Epstein-Barr virus DNA. Well, that shouldn't be a DNA. You should do a messenger RNA, right?
Right.
You're just transcribing to a messenger RNA. I think that must be serious. So that's the minimal that should be done and all that. Anyway, then I showed them the enterovirus stuff and all that. That was a letter to the editor. So anyway, but to get back to your point. So in AIDS patients, these herpes viruses are reactivated. They never really played any significant role. You can talk to the AIDS researchers. One of my friends is David Ho. I used to ask him, I said, have you seen much enterovirus infection in AIDS patients? He said, not really. People don't report it. Yeah, usually probably is not a problem, but we have certainly seen patients with coexisting AIDS and chronic fatigue syndrome. Usually they have chronic fatigue syndrome first, then they got HIV, and they hated the chronic fatigue syndrome. HIV can be treated now, right?
Yes.
So if HIV can turn on the herpes viruses, and then you look at this Incline Village cohort, so something hit them, most likely enterovirus. And what the researchers found in those early days, because they were able to test T cells, they saw a dramatic drop of CD8 positive T lymphocytes. They had an immune deficiency. Dr. Komarov et al., Deidre Bockwell and Peterson, Paul Cheney et al. And you can see this reversal of the CD4/CD8 ratio. Something obviously happened, right? And we have subsequently shown in patients who developed shingles, and they have this abnormality also. The CD8 drops, okay? And then all of a sudden they come up with shingles, but those patients, they have enterovirus in their throat or in their stool. So we documented that. And one time I was telling a dermatologist about my findings, okay? And he told me, listen to me. He said, in 2 days' time, I saw 42 cases of shingles. So what happened there? Something hit them.
Something else hit them.
The immune system. That is such an important thing. People talk about, you heard Dr. Nan talk about SSPE, subacute sclerosing panencephalitis, which is caused by measles. So people who have wild type measles, like 3 in a million people who develop this SSPE like 10, 15 years later. they become crippled. They can become aphasic. They get really bad. Some people may have died. But people talk about this hit. Something hit them.
Yep.
That hit they haven't figured out. I can tell you, enteroviruses are so common. If they can do this to cause shingles outbreak, Epstein-Barr reactivation is not a surprise. Herpes 6 is not a surprise. Yes, we treat what we can see, but then those patients often develop chronic fatigue syndrome after that.
Yeah.
So there's still something else there. That's the important thing. That's how clinicians, I look at this and then I go to the lab and I work on it. Then I kind of plug back in and then we see how this kind of reason it out. Okay. Yeah.
Great. Wow. Wow, John, this has been so informative and so interesting. You've done such incredible work over so many years. I respect you so much as a scientist. I'm surprised that you've stayed sane while many people have not acknowledged your work. I think it should be more widely disseminated, but I hope that now, my hope is that as people better look at the SARS-CoV-2 virus, better look at single-stranded RNA viruses, better look at the long-term consequences of some of these other infections, that may at least revive some interest in enterovirus, which is, I agree with you, are completely understudied and capable of driving a broad range of symptoms, including many of the ME/CFS cardinal symptoms. So thank you so much for your time. And maybe we can check in again later and you can give me
You're
some
welcome.
updates. All right. Sounds good, John. All right. Well, take care.
Okay. Bye-bye.
Bye.